Hello, everyone. I'm Nalini Gouda from Milwaukee, Wisconsin. It is my distinct pleasure and honor to introduce Dr. Kulwinder S to you today. Dr. Dua is a professor of medicine and pediatrics here at the Medical College of Wisconsin in Milwaukee. Trained in India, he went to England for further training before he came to the United States. He's a brilliant endoscopist, was recognized by the ASGE with the honorary Master of Endoscopy Award. He is always in the forefront with his innovations. We all know of the popular Dua stent, which is the anti-reflux valve stent. He's also recently credited for tissue regeneration, especially esophageal regrowth, which is a landmark in GI endoscopy. So welcome to the program. Welcome, Dr. Dua.
Thank you, Nalini, for that kind introduction. And I also want to thank ASGE and the editorial board of GI Endoscopy, especially Raju, for giving me this honor and for including me in this Meet the Master series. Thanks.
So, Dr. Dua, tell me what was the influence that you had early on to join medicine and gastroenterology. I know you, very few people know that you also fly planes, and you come from a family of pilots. And how did that transform into doing endoscopy?
Long story, but let me put it in a few words. When I was around 6, 7 years of age, I had polio and my left lower limb went weak and I had difficulty walking. At that time, it was difficult for me to understand why the doctors cannot fix me because I thought that's what they do. As I grew older, reality sunk in and I realized that my dreams of becoming a fighter pilot like my father, who was in the Air Force, is not going to happen, and felt a little bit dejected, besides the fact that I couldn't play cricket with my friends. My mother and my grandfather, my mother's father, who was a doctor, slowly started introducing the idea of medicine in my mind, emphasizing that if I become a doctor, I may have the potential of touching the lives of many more people like me. And then my elder sister joined med school, my brother joined med school, the whole climate in our house was med school, and I joined med school. And that's how it started initially. Now, why gastroenterology? After finishing my med school, I started doing post-graduation in internal medicine. And in India, as you know, Nalini, that you have to do a thesis to graduate from postgraduate college. And my thesis was on COPD. And by default, I became a pulmonologist. After finishing my post-graduation, I moved to UK, and my struggle was that I kept getting residency, what they call as senior house officer positions, most of them locum in pulmonary medicine, did a fair share of bronchoscopies, but at the same time, I found no light at the tunnel doing all these locum jobs. Then one day, I remember it was late in June, I got a call from the chair of gastroenterology from the Aberdeen Royal Infirmary, Aberdeen University in Scotland, who called me and said, "Hey, do you want to do 3-year fellowship in gastroenterology? To be honest with you, our candidate whom we selected just called us and dropped out. Can you join July 1? I was thrilled, but at the same time, I asked him, how did you pick me up? They said, oh, when you were doing a locum in Aberdeen in pulmonary medicine, there were some comments made about your hand-eye coordination when you were doing bronchoscopy. So we think that you will fit in very well in GI. And this is not a locum job. This is a 3-year fellowship. And that's where started my gastroenterology career. Now, those days, we had fiber optic endoscopes. the only way to learn was to attach a teaching attachment to the endoscope and two people can see at the same time. H. pylori was just being discovered. There were only H2 blockers, no PPI. And most of the endoscopic work was diagnostic. And the few therapeutic work that was going on was dilating peptic strictures, managing a large amount of people coming with duodenal ulcer bleeds, some gastric ulcer, and the usual colonoscopy diagnostic to rule out IBD and some polyps. Having said that, I was impressed how much accessibility we have with endoscopes. And although there were limited therapeutic options that were going on, my brain started thinking about what else can be done if we can reach so deep into the GI tract. And fast forward 35 years, not only you know how the whole field has exploded. There was no EUS at my time. Now look at what we can do with endoscopic ultrasound. Look at additional subspecialties like bariatric endoscopy, third space endoscopy, ablative therapies. And that was my kind of guess those years that's going to happen. And I was very excited about it. And at the same time, the challenge was, how do I keep pace with all these new innovations? There were no structured courses. I remember the first time when we got an endoscopic ultrasound machine, never held one before. Our hospital told us that you'll only get one, the radial or the linear. And we decided to go for the linear because we can do fine needle aspirations, but the learning curve was very steep. We got our radiology people in our room, self-learned, and then now we basically have all these, thanks to ASG courses, lectures that our younger faculty can go and train and become sub-specialist. So overall, I think I did make the right choice, and I'm glad that I went into GI and my interest in interventional endoscopy blossomed in the process. And the learning and keeping yourself updated was a bit of a challenge, but it worked out. I personally feel now is the time that you cannot become master of everything. I cannot become the world's best ESD and third space endoscopist and ERCP and EUS and all of that. No, we will have to now, for our younger generation, start picking up which part of interventional endoscopy that you want to be an expert in. There's no way we can do all of it. And slowly and steadily, people are beginning to realize that based on where they feel they are going to go and join in their practice. And stay tuned. Within a year or two, it's very easy to get outdated the way things are expanding and exploding in interventional endoscopy.
That's a great advice for all the young and aspiring endoscopists. Who had the most career influences for you? You know, you've obviously been through several systems of education through 3 different continents, and you yourself, you know, now are a very well-respected teacher, and you go out regularly giving lectures and talks. Who had the most influences on your career?
So my mentors in Scotland, Peter Brandt, who is a well-known hepatologist, retired now, Ashley Mowat, who was the only faculty in Aberdeen doing ERCPs at the time. Most of it were like diagnostic those days because MRCP was not there. Synchrotome and extracting a stone in a cholangitic patient was so impressive to me that it kind of further pushed me into interventional endoscopy. And the advice that I got from them was quite interesting. I mean, one day I remember Ashley Mowat told me, hey, come along, you want to do some ERCPs? Let's do some. And there were 3 ERCPs in those days, and I could candidate all 3 of them, and I was so excited, and they could see it on my face. And Ashley told me, you look very happy. And I said, yeah, I feel like an expert today. I could cannulate all 3 of these cases. He said, no, you become an expert the day you realize that the procedure is not indicated. And you become an expert when you realize when to quit. So these sort of subtle cues that they were giving me helped me like realize how our younger generation, including many of the 4th-year fellows whom I train, are so proactive in getting their hands on the scope. But did you go and see the patient? Was the procedure indicated? It is very difficult to say no to a surgeon who's pushing you to do a procedure than to say yes and just do it. So those kind of things really helped me to understand that we are physicians and not technicians. And as much as it is exciting to do all these US guided gastrojejunostomy, was it really indicated? Did you assess the patient? And then if you really thought it was indicated, you did it. What happened to the patient? So the learning is not successful intervention. The learning is what you did it work, and was it indicated? And that's what I keep emphasizing my fellows over here. Do not focus on learning techniques without understanding your patient first. In the same theme, I do tell them that you need to also start very soon developing an interest in what you want to do. You want to be an interventional pancreatobiliary person, and then you go somewhere in a remote place where you do private practice and you never get any complex cases. So why do you want to do endoscopic gastrojejunostomy? So tailor your needs based on what you plan to do down the road, and not try to do everything, because then you learn nothing. So these are certain influences which I got. My mentors were very conservative. It would take a lot to convince them to do a case, as much as they enjoyed doing interventional work, but that made me learn a lot. I also feel that we should not work and do all these advanced interventional procedures in isolation. Managing a, say, pancreatobiliary case not only involves our other colleagues, but also other disciplines. And to become a center of excellence, it's not just having 4 walls with all the advanced equipment. It's your surgeons, your oncologists, your interventional radiology, your guys who read the CT scans, dietitian, nutrition, nurse practitioners. We have genetic people in our multidisciplinary meetings. Same thing for esophageal cancer and esophageal intervention. It's a whole group in itself, and they make you the center of excellence in handling patients with complex needs. It's amazing how many times that people want to do an intervention, and in the multidisciplinary meeting, it's argued why. And you learn a lot from that. So I think my suggestion is that if you want to do interventional endoscopy work, you need to have a good crosstalk with every discipline and a backup service to bail you out if you run into trouble.
That's an excellent advice. I know you have a very busy practice. I know that because I practice in the same town. You're also busy, imparting knowledge to others. You give a lot of lectures. How do you keep the innovative side of your brain active? Because you're also quite the innovator.
It's interesting that people do recognize me for certain things, but how simple things are. Not only you do a lot of interventional work, and I'm sure in your career there was a time, even now also, where you'll go in with your endoscope and you'll say, "Oh, I wish I had something that would do this for me." That makes you think. That makes you, well, can I actually make that equipment? So, for example, when I first time had a case over here when I moved, and we had a patient with a GE junction cancer, and I put an esophageal stent. I was so thrilled about it. It was an expandable stent, and I was used to those rigid old plastic prostheses. And the expandable stent was kind of like, wow, what an invention. Until 3 days later, the man died from aspiration, which was so disheartening. And it is just a simple observation. Hey, in this part of the world, we have GE junction cancer, unlike squamous cell cancers in other parts. We have to put stents across the GE junction. Why can't we attach a valve to it? And you think, I think that is the most crucial part. Now, taking it to the lab and developing it, I think is an easier part. The thinking process of what you need drives your invention. We had a patient, as you mentioned earlier, who had completely lost 5 centimeters of his esophagus from a mediastinal abscess. You scope him, and from the hypopharynx, you go into the esophagus. You have nothing else. Go into the mediastinum. There's nothing else there. Then you talk to your people who work with stem cells, extracellular matrix, stents that can form a scaffold, and a need that drove you to think, that drove you to the first case where the esophagus was grown, all 5 layers shown on endoscopic ultrasound, using some techniques that have already been practiced on compassionate grounds. So this is the way I would recommend that whenever anybody is scoping, or even not scoping, and you feel that I wish there was something that could do this for me, that is the beginning of your innovation. And believe me, not only in interventional endoscopy, even in standard endoscopies, why do you see so many snares out there? Because somebody felt a need. I wish I had a snare that could do this. And that is how in interventional endoscopy. Now, also don't forget that a lot of techniques and a lot of devices come out, but they are like, see what I can do, see how many I have done, but whether worth doing, that requires evidence-based medicine. And that is where I think the third part of that question needs to be answered with all these devices, techniques, and all that come out. Even the anti-reflux esophageal stent that I have made, see what I can do, see how many I have placed, but was it worth doing it? Well, somebody would argue I would just give PPIs, and I want them to challenge it. You challenge it, you get stronger with your invention if it is really working. So these are certain things that I think come in the routine for anybody who's doing interventional work. As far as teaching is concerned, I thank ASGE very much for introducing me around 10, 12 years ago to the ASGE Ambassador Program. And I went to Ecuador, followed by some third world countries, now mostly in Africa. And what struck me was that how those people are begging for somebody to come and give them hands-on training. Unfortunately, they have come to my center many times, they can only observe. And observership does help, but it's not the same thing as hands-on. So I started developing a, like just a general policy. Hey, you come, you watch me, how I do procedures here. I'll come to your place and you line up cases and I'll give you hands-on. And 3 centers, I started ERCPs, and they are now doing much more than I do. There's a center who's now getting into EUS. There's another center in Nigeria now that also got certified for ERCP. All it took was me going there, spending time, and at one center had 35 cases lined up. I don't know, there's so much of disease over there. So what I had to do in the process, or I had to sacrifice, is a couple of weeks of my 4 weeks of vacation time. You only get so much vacation time. You only get so much of academic time to take in your career. Market forces are driving us nowadays so much. And in that regard, if anybody, junior faculty or even senior faculty who are in the retirement phase, can donate a week of their vacation time and train people locally. And that local center then becomes the center of excellence. And they then train another 100 people. And that 100 people train other people. It multiplies. And this is one thing that I have now realized, how we can go and help others by just donating your vacation time and giving them hands-on training. And believe me, going there is a vacation in itself. They look after you. They are so happy that you can come and train them. And they then, of course, you go to a place, you would like to see something in that place. I mean, Ethiopia, for example, in Addis Ababa, where I started about 8-9 years ago, has now become the Center of Excellence, also recognized by the WGO as Center of Excellence. And they are now training so many other people. And Ethiopia is a beautiful country. There are a lot of things to see over there. So I think it's not necessarily donating your vacation time. It's also a vacation in itself. I think this way we can then carry some expertise, whether it is basic colonoscopy or upper endoscopy to advanced stuff, to countries who are desperate to provide this service.
That's a great advice, and I'm sure people who are interested in their younger career development phase can reach out to you for opportunities. Of all the things you do, I know you enjoy doing endoscopy, complex procedures. You teach, you go lecture, you travel. What are you the most passionate about?
It used to be, and I think it is still, doing challenging cases. But now I'm beginning to realize it's to see how people you train, whether it is an individual or whether it is a center, that you held their hand, brought them to a level that is kind of so gratifying to see the success stories of what you did. To go and see a center that is now doing 35 ERCPs per day when they couldn't even do one. To go and see my fellow who is now serving in ASG committees and is now a big person blossoming up. I am beginning to find that more gratifying at this point in time, because as I mentioned, there was nothing like now when I started my GI training in Aberdeen. And this whole 35 years was my crazy life. Anything new that comes, I have to learn, carry it to my division if it is established as an evidence-based procedure. From that, you try to get into bariatric stuff that you had never done before. You try to learn that, and then you get exhausted. You can't keep pace with the development. And at that point, you start wondering, what is pleasing you? Why do you want to do this? Why do you want to show the world you can do ERCPs, you can do EUSs, you can do interventional EUSs, you can do bariatric, you can do EMR, you can do ESD? No, it's not worth it. You basically have some excellent skills that you develop, pass it on. I think I personally feel that if you are an accomplished person like you are yourself and others, they stand to commit two big mistakes. One is not use their skills, and second, not pass it on to others. And I find that passing it on to others so that they can carry the torch with them down the road and keep up with new developments that are coming, that I'm finding more gratifying nowadays, whether it is a fellow here in my medical college or whether it is a center of excellence in Africa or South America, or there's a center even in India, Central India, that I had introduced them to ERCPs, and they are doing much more than I do. So I find that is teaching is now becoming a little bit more gratifying. Yeah.
That's great. Um, I know I could talk with you and you can impart your wisdom forever. But before we conclude the program, I would like to ask you, you have a beautiful family. I personally know them. It's very hard these days to balance your career demands and your own personal growth, and you have a family to look after. For the generation of the new endoscopists, what is your advice to have a proper life career balance?
A word of wisdom here, and that is, no matter how professionally you have succeeded in life, it is not worth anything if it has come at the cost of your family. It is very easy to not only work late hours because people are wanting you to do a specific case. You get a call from your surgeon, hey, I only want you, and you feel very accomplished and kind of proud, and you work and work, and you are coming home at 8, 9 o'clock. Then on the weekend, you catch a plane and you are somewhere in Europe giving a talk. This goes on until your wife says, you know what, our eldest daughter is graduating. Oh, she's grown that big. How did, what was I doing all this time? That is a trap you tend to fall into for getting into your professional life and trying to excel in your professional life. I sincerely tell everybody that family life is equally important. And if at the end of the day, at my age, my family life is ruined, I don't think, with hindsight, I would have said that I would give away my professional accomplishment anytime to turn the clock back and restart. So please, please do give enough time to your family. Kids grow very fast, and not very soon you'll realize that they are already in college. They no longer care whether you are at home or you are gone on a travel. And that is sad. That is sad.
It was great chatting with you. I know we could continue on and listen to all these stories, but we will wind up the program for today. Thanks for sparing your time and sharing with us all your life experiences. Thank you.
Thank you, Nalani, for doing this. And again, thank you, editorial board of VideoGIE, for giving me this honor.